Hello, my name's Emily, and my quality assurance video is on a recent patient that I had who presented to the lab for a follow-up carotid duplex with a history of a bilateral 70 to 99% stenosis at the proximal ICA. The right proximal ICA peak systolic velocity was 283 over 21 centimeters per second with calcific plaque and acoustic shadowing. And the left side at the proximal ICA peak systolic velocity was 421 over 86 centimeters per second with calcific plaque and acoustic shadowing as well. The patient's previous exam revealed a 70 to 99% stenosis at the proximal ICA bilaterally as well. However, an image measurement was obtainable at 75% on the left side, even though there was still acoustic shadowing. But in this study, in my exam, with the acoustic shadowing, I wasn't able to obtain an image measurement. So I learned that an image measurement is not always obtainable with calcific plaque because of the shadowing that it casts. However, if you change your scan plane to visualize more of the ICA plaque to work around the shadowing, it can be very helpful to try to get that image measurement. I had Dr. Henke review my case with me. I asked him a few questions regarding high-grade stenosis in the carotid arteries. My first question was, what criteria do you use to determine whether a patient is a candidate for intervention? And he said, primarily I operate if the patient is symptomatic. However, other criteria I use includes a diastolic velocity over 100 centimeters per second, CTA indicating a greater than 80% stenosis. However, this patient was asymptomatic, so he was not a candidate for revascularization. The second question I had for him was, how do you determine which type of intervention is best for a patient with a high-grade stenosis? And he said that there is a greater risk for stroke with stenting procedures. Patients that have had a previous neck surgery, a re-narrowing of an endarterectomy, neck irradiation, are allergic to anesthetics, or have a medical history are recommended for stenting. He also said that there's a greater risk for myocardial infarction with an endar, and then medication therapy is usually recommended for patients that are asymptomatic, like this one, which usually outweighs the risks for stenting procedures. He also included that a flow limiting factor isn't the only consideration, but also the risk for embolus when determining if intervention is suitable for a patient. My final question for him what is the significance of visualizing the top of the ICA plaque, which we have to include in our report. And he said that you must visualize the top of the plaque to get a clamp above it during surgery. And if the plaque is above the jawline, the clamp won't reach high enough to get to it. So I did learn a lot from doing this quality assurance video, and I hope you enjoyed it.